Welcome to the Radonc Smart Review Head and Neck Cancer Series.
We're launching into a really comprehensive review today. It's a topic that's, critical, but also a bit of a niche area of practice. Definitive radiation and brachytherapy for oral cavity cancer.
And that framing is so important, especially for residents. We have to start with the absolute anchor point here. Oral cavity cancer, OCC, is fundamentally a surgical disease. If a patient is medically fit and, the tumor is resectable, then primary surgery, glossectomy, mandibulectomy, neck dissection, that is the standard of care, full stop.
Right.
But of course, the real world of medicine, and definitely the oral boards, they throw curveballs. They give you these scenarios where surgery is contraindicated or just flat out impossible.
And that's our whole mission today.
Exactly.
We're focusing on those necessary life-saving alternatives.
Yeah.
The situations where the surgeon basically hands the case over to us. And our goals are really specific.
Right.
We need to nail down the appropriate outcomes. What to expect for local control. We have to master the dose fractionation schemes, especially how to build a definitive SIB plan. And maybe most importantly, we need to explore that specific, very high-yield role of interstitial brachytherapy.
For those selected early-stage cases.
For selected early-stage OCC.
Yeah. Okay, so let's jump right in with a classic board-style presentation. I think using a clinical case is the best way to ground every decision we're about to make.
Absolutely. Please set the clinical stage for us.
All right. We have a 76-year-old female patient. She presents with a 2.5 centimeter squamous cell carcinoma, and it's located pretty typically on the right lateral oral tongue.
Okay, classic spot.
Imaging, specifically a dedicated MRI, confirms a really critical measurement. The depth of invasion, or DOI, is 7 millimeters.
7 millimeters. Okay, I'm flagging that.
She is clinically N0, M0, so what we're dealing with is clinical T2, N0, M0, stage 2 disease.
So a T2, N0 oral tongue SCC, that's textbook resectable. That's a partial glossectomy and an elective neck dissection, probably levels 1 through 4.
Exactly. But here's the complication. This is the crucial wrinkle that shifts this whole case from a surgical problem to our problem.
Her medical status.
Her medical status.
Yeah.
She has severe congestive heart failure, and it's documented with an ejection fraction of just 20%.
Yeah. Cool.
She had a significant MI just 6 months ago and is on chronic multi-agent anticoagulation for AFib. Her surgical team has consulted cardiology, they've consulted anesthesiology, and the consensus is clear. She is a prohibitive surgical risk.
So they just can't safely put her under then?
They can't. They can't manage the general anesthesia and the acute bleeding risk that comes with a major ablative surgery and a neck dissection.
This is it. This is the definitive scenario. The tumor is, technically resectable, but the patient is medically inoperable. So the clinical question just changes completely.
Right.
Now it's, what is our definitive curative radiation option? This is where you need to synthesize a whole treatment strategy, and that requires a really crisp, board-ready summary.
Okay, so give us that summary, exactly as you would deliver it in an oral board setting.
Examinee. This is a 76-year-old woman with clinical T2N0 squamous cell carcinoma of the right oral tongue, who is medically inoperable due to severe cardiac comorbidity. I would recommend definitive radiation-based management with curative intent. Given that the depth of invasion is 7 millimeters, which places her occult nodal risk well above the 5 millimeter threshold, I would treat the elective neck even with clinically N0 disease. For the primary tumor, I would offer 2 definitive options. Either IMRT to 70 gray with a simultaneous integrated boost technique, or interstitial brachytherapy to the primary at a center with high expertise, always paired with 54 to 56 gray elective neck irradiation to address the regional risk. I would counsel her that for early-stage oral tongue cancer, definitive radiation can achieve local control comparable to surgery, but the acute and late toxicity burden, including severe mucositis, persistent xerostomia, and a real risk of osteomedial necrosis, is substantial.
That is robust. You immediately hit the primary, the neck, the alternatives, and you framed it all within her medical inoperability. But let me push you on something there.
Sure.
The sequencing and risk. This patient is frail. Is a 7-week course of daily radiation, which we know guarantees grade 3 mucositis. Is that actually a safer approach than one single acute surgical event?
That is an excellent clinical question, and it really highlights the paradox, doesn't it? We're trading this acute, immediate, perioperative risk-like anesthetic death or a major bleed on anticoagulation for a more subacute, severe systemic stress that's drawn out over a longer period. For this specific patient, though, Her cardiac risk is just so severe. I mean, EF of 20%, recent MI, the surgical team has just said no. They vetoed the OR.
Right.
So while the long course of radiation is definitely morbid, it avoids that immediate massive stressor that could cause, catastrophic acute cardiac failure. We just have to manage the radiation toxicity, super aggressively prophylactic feeding tube, aggressive pain management
Yeah.
to mitigate that systemic drain.
So it's the lesser of two very severe risks.
Exactly. It's not about it being easy. It's about it being possible.
Got it. Okay, let's step back for a second and just anchor this entire decision-making process. The foundation, like you said, is that oral cavity cancer is not an organ preservation site.
Exactly. It's not like the larynx or the oropharynx. The primary goal for OCC is still maximum tumor eradication with the lowest functional morbidity. And, historically, surgery has achieved that best balance. But the exceptions do exist, and they are very distinct, and you need to have them memorized.
Let's detail those three distinct board-safe indications. We've talked about a mnemonic before, MRU.
MRU. So the M stands for medical inoperability. This is the exact case we're talking about now. The patient is prohibitive risk due to severe comorbidities, cardiopulmonary, renal failure, just severe frailty. And we have to be sure this is a genuine medical impossibility, not just a difficult case.
Right, needs to be documented.
A discussion with the cardiothoracic team or high-risk anesthesiology is key to documenting just how severe it is.
Okay, so that's M. The R stands for patient refusal.
Right. This is all about patient autonomy. After a very thorough, well-documented counseling session where you confirm that surgery is the preferred or, gold standard approach, the patient still has the right to refuse a procedure.
And you have to document that conversation.
Oh, absolutely.
Yeah.
You must clearly document that the patient understands the increased risks, like local failure or maybe greater functional impairment compared to the surgical approach. This scenario, by the way, often opens the door for definitive brachytherapy if the tumor is small enough.
Interesting. Okay, and finally, the U.
The U is for truly unresectable disease, T4B type. This is actually pretty uncommon for a typical tongue or floor of mouth cancer, which are usually T4A, meaning they're resectable even if they invade the mandible.
So T4B is surgically impossible.
Impossible. Think massive invasion of the skull base, complete encasement of the carotid artery by bulky nodes, or really deep extension into the parapharyngeal and deep masticator spaces that just prevents any kind of safe, margin-negative resection. If the surgeon simply cannot get around it, it becomes a radiation-only problem.
MRU, medically inoperable, refusal, unresectable T4B. That defines our population. Okay, now let's dive into the outcomes, because this conversation totally changes based on the T stage.
It really does. For early-stage disease, T1 to T2 and 0, our confidence level is actually quite high. In well-selected patients, and by that I mean those who don't have these deeply fixed, really ulcerated tumors, definitive radiation can get local control rates that are comparable to surgery.
And what does that mean in numbers?
Historically, we're talking about local control in the ballpark of 75 to 80% at 5 years. And that impressive parity for early disease is the oncologic justification for going ahead with curative intent for our medically inoperable patient. We're not offering palliation here, we are offering a cure.
But that narrative just flips completely the moment we move into advanced disease. The comparison to surgery becomes pretty unfavorable for radiation alone.
It does. For advanced stage disease, T3 to T4, the overwhelming consensus is that primary surgery is superior. When you treat a bulky advanced OCC with definitive radiation, the high-dose volume you need is just massive.
Which leads to more toxicity.
Dramatically increased late toxicity, especially ORN, and the local control rates drop significantly, sometimes down into the 60% range, or even lower.
And the risk of failure is then compounded by how morbid the salvage is.
Absolutely. If a large primary fails after 70 gray of definitive radiation, the salvage surgery that follows is often devastating. It typically requires these huge composite resections, free flap reconstruction, and it carries much higher rates of perioperative complications compared to doing surgery first.
And the chance of it working is lower.
Much lower. The probability of a successful salvage is much, much lower. And this is the crucial evidence that supports that surgery first mantra for operable advanced OCC. You want your best shot at a cure and the lowest functional morbidity right up front.
Okay, before we get into the EVRT specifics, you flagged it earlier, let's talk about the evidence behind that 7mm depth of invasion trigger from our case. Why is DOI the key driver for elective neck treatment?
Yeah, this is so important. It's based on decades of retrospective data, often anchored by these classic series, from places like MD Anderson. They looked at occult nodal disease in clinically N0 necks.
And they found a cutoff.
They found that the threshold where the occult nodal risk becomes clinically meaningful, let's say greater than 20%, is typically tied to the DOI. And modern consensus kind of centers around a cutoff that's somewhere between 4 and 7 millimeters.
Can you elaborate on that range?
Sure. So if the DOI is less than, say, 4 millimeters, the occult risk is generally low enough, we're talking below 10 to 15%, that some surgeons might even consider observation. Or we might skip elective neck treatment if we were doing primary brachytherapy.
But once you cross that line...
However, once that DOI hits 5 millimeters and certainly at 7 millimeters, like in our patient, the occult risk can be as high as 30 to 40%.
Wow, that's high.
It's very high. And this data, it's been confirmed across multiple large retrospective series. It just compels us to treat the neck. If we only treat the primary tumor, we are knowingly leaving a high probability of regional failure, which is almost always incurable without very aggressive salvage surgery later on.
So that 30 to 40% risk, that's the core justification for including that 56 gray elective nodal field, even if the PET scan is totally negative for gross disease. Okay, this brings us perfectly into the mechanics of treatment. Let's start with external beam radiation therapy, or EBRT, planning. If you are in a definitive treatment scenario, you have to know the board default dose cold.
The anchor dose. For definitive EDRT to gross disease, it's 70 grays in 35 fractions using IMRT or VMAT.
And obviously, we don't just treat the whole neck to 70 gray. Modern planning uses a dose painting or simultaneous integrated boost, an SIB approach. So let's map out that standard three-tier dose hierarchy.
Okay, so the GTV, which is the gross primary tumor and any visible gross nodes, that gets the full oncologically definitive dose, 70 gray in 35 fractions.
Right.
Then we design the first CTV contour. This is the CTV high risk. It includes the GTV plus a generous margin for microscopic extension, typically 5 to 10 millimeters, making sure we cover all the high-risk tissues around the primary. And that region gets 63 gray in 35 fractions.
And then the prophylactic, the elective nodal regions.
Right, the CTV elective nodal regions where we are prophylactically treating for that occult nodal risk we just discussed.
Yeah.
So levels 1B through 3, if laterally, they get the lowest dose, typically 56 gray in 35 fractions.
So that 706356 gray scheme, delivered all at once in 35 fractions, is the standard resident answer for definitive head and neck IMRT.
That's the one.
Reciting the dose is the easy part. Let's talk about the technical challenge. Why is it so hard to deliver 70 gray to a tumor that is millimeters away from the mandible? How does IMRT help us here compared to, older 3D CRT techniques?
Yeah, that's where this really gets tricky. Oral cavity planning is just inherently challenging because of how close the mandible is, which, as we said, is the major limiting structure. The whole advantage of IMRT is beam shaping and dose conformality.
Right.
With 3D CRT, a 70 gray box field covering that primary would inevitably blast a massive volume of the mandible the same dose, which would basically guarantee ORN.
Which is unacceptable.
Totally unacceptable. IMRT lets us wrap that high-dose volume really tightly around the tumor, avoiding that dose spill into uninvolved parts of the mandibular bone. Specifically, we focus on minimizing the high-dose volume, the V63 or the V70 to the bone, that isn't directly invaded by the tumor.
Okay.
We accept that the part of the mandible right next to the gross tumor might get 70 gray, but we work really hard to drive that dose gradient down rapidly across the bone, trying to keep the overall mean dose and the volume getting those high doses below certain tolerance levels.
Let's revisit the rationale for 70 gray itself. You had a great analogy earlier, the act of wildfire versus clearing embers. Can you tie that back to the biological requirements?
Sure. We are fighting gross disease here. The dose requirement is directly related to the number of clonogens we have to sterilize. While we use 60 or 66 gray in the adjuvant setting to clear up microscopic residue, which is a lower clonogenic burden.
Right, the embers.
The embers, exactly. We need 70 grays to achieve a high probability of local control for a palpable or a visible tumor mass. This high dose helps overcome things like tumor hypoxia and the inherent radioresistance of larger cell populations.
So if a resident is presented with a definitive case and they offer anything less than 66 grays, or certainly less than 70 for the gross disease, they are just fundamentally undertreating a potentially curable patient.
Precisely. If they say 60 Gui, they're treating it like a microscopic margin, and the local failure rate will be unacceptably high. You just need that extra biological punch, that, roughly 15 to 20% extra dose, to sterilize the active, bulky tumor.
Okay. Now, briefly, what about acceptable alternatives? We've got 70 and 35 as our anchor, but what other techniques might an institution use?
There are acceptable alternatives, things like hyperfractionation, where we might use more smaller fractions over the same time, or accelerated fractionation, which shortens the overall treatment time to fight tumor repopulation. A common accelerated scheme might be a concomitant boost technique, where you treat the primary twice a day for the last few weeks, or maybe an accelerated 6 fractions per week scheme. All of these are defensible, but for the boards, 70 and 35 SIB is the safest, most established answer.
Got it. Okay, let's shift to systemic therapy. This is an area where, clinically and on exams, residents can fall into the trap of overtreating these early cases. When do we add concurrent chemotherapy to definitive oral cavity radiation?
This guidance is so crucial. Do not automatically add chemotherapy to early T1 to T2N0 cases treated definitively. For our 76-year-old T2N0 patient, radiation alone is entirely appropriate and standard.
Right, because the data is weak.
The data supporting a chemo benefit for early N0 disease is weak, and the additional toxicity in a medically frail patient is just unacceptable.
So when does that balance shift? When do we bring chemo into the plan?
We reserve concurrent systemic therapy, so moving to definitive chemoradiation for the higher-risk scenarios.
Yeah.
Confirmed node-positive disease, N1, N2, N3, bulky primaries, so T3 or T4, or situations where we just suspect poor local control with radiation alone. We're sort of guided here by the general head and neck literature, like RTOG 9501, which showed that chemoradiation benefit for locally advanced disease.
And the agent of choice.
Cisplatin. Always state that cisplatin, delivered IV every 3 weeks or weekly, is the standard concurrent agent. It's the drug with the highest level of evidence for radiosensitization in this setting.
But what about our patient, the 76-year-old? She's already frail. Let's say she has a creatinine clearance of 40. That makes high-dose cisplatin really challenging. What's our plan B?
Okay, good question. If a patient is truly contraindicated to cisplatin due to poor renal function, bad neuropathy, extreme frailty, we have a couple of alternatives, though both are technically inferior. First, a weekly, lower-dose carboplatin-paclitaxel combo, though that's less common in this setting. Second, and probably more common in a frail population, is cetuximab, a monoclonal antibody targeting the EGFR pathway.
Right.
But while cetuximab showed a benefit in the ER-BC study, it's generally considered the agent of choice only when cisplatin is truly impossible. Cisplatin is still the gold standard. So in a case like our frail T2N0 patient, the most defensible choice might still be radiation alone, just avoiding the systemic burden entirely.
That's excellent nuance. Okay, now let's pivot to what you called the highest yield niche topic for definitive oral cavity treatment, interstitial brachytherapy. This is highly specialized, often only done at big academic centers, but understanding its role is essential for the exam.
It is specialized, but brachytherapy gives you this unique advantage. You're delivering an extremely high localized dose right to the tumor while getting a really rapid dose fall-off, so you spare all the adjacent critical structures.
So it has two main roles.
Two primary roles here. Role 1, definitive monotherapy for very early select lesions, like a T1. And role 2, a highly targeted boost combined with external beam radiation for slightly larger lesions, like a T2.
Okay, let's focus on that definitive monotherapy scenario. What is the ideal candidate? We need that strict checklist, the one the examiners want to hear, that emphasizes all the technical constraints.
The best candidates are small, well-defined T1 lesions, maybe up to 2 centimeters of the oral tongue or the anterior floor of mouth. Crucially, they have to be accessible for implant geometry.
What does that mean exactly?
It means the tumor must be exophytic and mobile enough that you can actually insert multiple parallel catheters or needles to get a uniform dose distribution. They also have to be confirmed to be without bone invasion or fixation to the mandible.
That seems critical.
It is. And finally, the location has to allow for safe catheter spacing and dosimetric coverage without creating hot spots in the skin or the mucosa.
We have to hit the nodal nuance again, because this is the major pitfall of monotherapy brachytherapy. If it perfectly sterilizes a T1 primary, why do we still have to worry about the neck?
Because brachytherapy, even if it's perfectly successful, only treats the primary with a high dose. It does not address that subclinical or occult nodal risk that's just inherent to squamous cell carcinoma.
So even if the tumor is small?
Even if that T1 tumor is small, if it has a DOI that is clinically meaningful, so 5 millimeters or more, we have to treat the neck.
Which means the definitive plan becomes a hybrid approach.
Precisely. If we choose brachytherapy for the primary, the standard approach is to pair it with elective neck IMRT to 56 gray or 54 gray, treating levels 1B through 3 ipsilaterally. And the benefit here is huge.
How so?
You spare the entire oral tongue, floor of mouth, and the salivary glands from the toxicity of 70 gray of external beam. You're basically substituting a 7-day brachy course for the last 4 weeks of an external beam boost, and that significantly improves the toxicity profile for the primary site.
Let's review the core dosing concepts. Can you distinguish between low dose rate, LDR, and high dose rate, HGR, monotherapy, and maybe touch on the radiobiology?
Sure. For LDR as monotherapy, which usually means an inpatient stay where the source stays in for days, the dose is quite high, about 60 to 70 gray, delivered continuously over 6 to 7 days. The low dose rate, around 0.4 to 0.6 gray per hour, offers a significant radiobiological advantage.
Which it?
It allows for sublethal damage repair in the surrounding normal tissues while it's continuously irradiating the tumor. That's really key to minimizing late toxicity.
Okay, and what about HDR monotherapy, which is more flexible technically?
HDR is often done outpatient, with the sources delivered in these discrete high-dose pulses. We aim for about 60 gray total. A common fractionation scheme is 5 gray, twice daily for 12 fractions. The total time is usually about 5 to 6 days.
So it's faster.
It's faster. But the HDR does lose some of that biological sparing advantage of LDR because of the high fraction size. But it's often favored just for its logistical simplicity.
This is a great point for a deeper biological dive. Given how quickly squamous cell carcinoma can repopulate, how does that continuous LDR delivery, which is inherently protracted, maintain its efficacy?
It's a trade-off. While the overall treatment time is longer with LDR, the continuous low-dose exposure works against the rapid repair mechanisms of the tumor. For SEC, which has a low alpha-beta ratio, both high fraction size like HDR and continuous low-dose like LDR are highly effective.
So how does LDR capitalize on that?
LDR really capitalizes on the difference in repair kinetics. The rapidly proliferating tumor cells, the OCC, they have very limited time to repair. But the surrounding slower proliferating normal tissues like the tongue muscle, they can repair that damage effectively during the low-dose exposure. That differential repair is the whole key to getting a better therapeutic ratio.
Okay, and just quickly, in the combined therapy scenario, EBRT plus a brachy boost, what are the doses?
So the external beam handles the regional lymphatics and the subclinical disease around the primary. A typical schedule might be external beam to 45 or 50 gray to the primary site and neck, and then that's followed by a brachytherapy boost to bring the total biological equivalent dose, the BED, up to 75 or 80 gray, but focused exclusively on the gross tumor volume.
Minimizing the dose to the rest of the tongue.
Exactly.
Now we have to address the critical contraindications. This is a guaranteed board check. When is brachytherapy unsafe in the oral cavity?
The rule is an absolute contraindication. You must avoid proximity to bone due to the unacceptable risk of osteoarterial necrosis, ORN.
Right.
Oral cavity bone, especially the mandible, has a really limited vascular supply. Delivering an ultra-high localized dose from brachytherapy, even for a short time, combined with the inevitable minor trauma of just chewing and moving, leads to a devastating ORN risk.
So which anatomical locations are just functionally off limits?
Gingiva, the hard palate, and the retromolar trigonum. These are the spots where the tumor is sitting directly adjacent to or is fixed to the underlying bone, the mandible or maxilla. If an examiner suggests implanting a lesion of the lower gingiva, your immediate and firm answer must be no, due to the prohibitive ORN risk.
Crystal clear. Okay, that brings us to the general workup and planning for definitive external beam radiation. Before we even think about simulation, what's the one mandatory clinical step that has to be completed?
A mandatory comprehensive dental evaluation and clearance is required for every single patient undergoing definitive radiation for oral cavity cancer. Given the high dose is 70 gray, the risk of late ORN and accelerated dental decay is just significant.
What are the specific protocols around dental extractions?
If the patient has any questionable teeth, infections or teeth that are just unavoidable in the high-dose field, so typically above 60 gray, those extractions must be done before treatment.
And there's a healing time.
A minimum of 10 to 14 days of healing time post-extraction before you start radiation. Starting radiation on an unhealed socket is just a fast track to ORN, and we also counsel them on daily fluoride applications for the rest of their lives to prevent decay later on.
Okay, let's walk through the setup for the IMRT planning session. What do we need to ensure for geometric reproducibility?
The setup details include the patient positioned supine, secured with a 5-point thermoplastic mask that goes over the face and shoulders. The neck should be extended as much as is tolerable, and we use shoulder pull-downs. Crucially, a custom bite block or dental stent is often used.
And that does two things, right?
Does two things. It helps immobilize the tongue, and it separates the maxilla from the mandible, which pulls the tongue a little bit inferiorly and helps us minimize high dose to the salivary glands and to uninvolved bone. And we always need IV contrast during the CT sim for the best vascular and nodal delineation.
Okay, now target volume definition. Let's get technical with the GTV-CTV hierarchy, especially focusing on that subsite-specific nodal coverage.
Okay, GTV is the gross disease you can see on clinical exam and on imaging. The CTV high risk is the GTV plus that margin for microscopic extension. This margin is often 5 to 10 millimeters, but you have to be careful not to expand it to bone or air where extension is unlikely.
Now for the elective nodal coverage. This is all determined by the primary subsite. So how do we map the nodal levels for a well-lateralized oral tongue lesion, like in our case?
For a well-lateralized lesion of the oral tongue, the primary drainage is ipsilateral, so we must cover levels 1B through 3. Level 1A, the segmental, is often included for anterior floor of mouth or tip of tongue, but for lateral tongue, 1B is key. We'd also typically include level 4 inferiorly because of that high DOI, the 7 millimeters, and the concern for skip metastases.
And level 5.
We generally try to spare level 5 unless there's posterior extension or gross disease.
And what's the rule when the tumor's midline, like a big floor of mouth lesion?
Any tumor that is midline or crosses the midline, especially floor of mouth, has significant bilateral lymphatic drainage. In that scenario, bilateral elective coverage is standard.
So you're treating both sides.
We would treat levels 1B through 3, maybe level 4, on both sides to that 56 gray elective dose. But this comes at the cost, of course, of bilateral salivary gland irradiation.
And let's just reiterate that key trigger one more time regarding DOI, even for an N0 patient.
The DOI is the non-negotiable trigger. If the depth is significant, so above that 5 millimeter threshold, you treat the elective neck, regardless of a negative PEOT scan. PE scans just have sensitivity limitations for small occult nodes, and that 30 to 40% occult risk is way too high to ignore.
Okay, moving to organ at risk, OAR priorities. We've established the mandible as number 1, so what are the technical goals in planning?
The major planning goal is preserving mandibular integrity. We have to minimize the high-dose volume, the V70, to the bone that is not involved by the tumor. For the mandible's cortical bone, we try to keep the dose to the inferior aspect, the part farthest from the tumor below 60 gray, if possible, though that's often very difficult. We also aim for the Dmax, the max dose to the mandible, to be contained below, say, 75 gray to mitigate the risk of ORN.
And what about the impact on quality of life, the salivary glands and the trismus structures?
Xerostomia risk is inherent, especially with that bilateral neck treatment for a floor of mouth lesion. When treating unilaterally, we have to aggressively spare the contralateral parotid gland, aiming for a mean dose objective below 26 gray to preserve some functional salivary flow.
And bilaterally.
When treating bilaterally, we just have to accept that the submandibular glands are almost always in the high-dose CTV because of level IB coverage, so we focus on maximal sparing of the parotids. Furthermore, you have to carefully evaluate the dose to the pterygoid muscles and the temporomandibular joint, the TMJ. High doses here lead to trismus, which really impairs speaking and eating.
Okay. This leads us right into patient counseling. We can't afford to undersell the toxicity when we're talking about a 7-week definitive course. Let's detail the acute versus the late risks and what we do to mitigate them.
Acute toxicity is dominated by grade 3 mucositis. Within 3 to 4 weeks, the patient will have these confluent areas of painful sloughing mucosa. Swallowing becomes nearly impossible.
So mitigation is mandatory.
Absolutely. Proactive pain control, often including high-dose opiates, and nutrition planning. For frail patients like ours, you have a very low threshold for early placement of a PEG tube, a feeding tube, just to prevent unplanned hospitalization and weight loss, which can stop treatment.
And what about the dreaded late toxicities, the ones that permanently impact quality of life?
Late toxicity includes severe, often persistent, xerostomia dry mouth, which requires lifelong management. There's chronic pain, dysgeusia, which is altered taste, debilitating trismus, which limits mouth opening and the risk of dental decay.
But the most catastrophic one is ORN.
The most catastrophic late complication is osteoradionecrosis. Because we're using these definitive doses right near the cortical bone, the ORN risk is real. It's estimated to be between 5 and 10%, especially if the patient needs dental work later on. Counseling has to include the protocol for post-treatment dental care, which means strict avoidance of tooth extractions and the potential need for hyperbaric oxygen therapy if ORN does happen.
Right.
This whole spectrum of life-altering late complications is the central reason why primary surgery, with its often lower long-term tissue dose, remains the standard of care when it's feasible.
Okay, let's transition into our final board review segment. We're going to focus on integrating all this knowledge, identifying the common traps, and really solidifying the essential clinical anchors.
Yeah, and understanding the traps prevents the most common errors that residents make. Applying the paradigms from other sites, like the oropharynx, to the very different biology and toxicity profile of the oral cavity.
Okay, trap 1. Offering definitive chemoradiation for a healthy, operable T2N0 oral cavity patient. So a 35-year-old with a T2 tongue tumor, non-smoker, no comorbidities. You suggest definitive treatment to save their tongue.
Wrong. That patient is an ideal surgical candidate. Oral cavity cancer is not a standard organ preservation site. Surgery is the default treatment.
Trap 2. Reflexively adding systemic therapy to all definitive cases. Our medically inoperable 76-year-old T2N0 case, you say definitive chemoradiation with cisplatin.
Wrong again. For T1 to T2N0, radiation alone is appropriate, especially given that patient's frailty. Chemotherapy just adds toxicity without any proven benefit in the N0 setting.
Okay, trap 3. Recommending interstitial brachytherapy for a lesion that's located on the hard palate or the lower gingiva.
Wrong. This is an absolute contraindication. The proximity to the maxilla or mandible makes that ORN risk completely unacceptable.
Okay, now let's list the 6 high-yield anchors, the essential clinical pearls from this whole review.
All right. Anchor 1. Definitive radiation is only for the MRU scenarios: medical inoperability, patient refusal, or unresectable T4B disease, never for a healthy, operable patient.
Anchor 2. Depth of invasion, DOI, is the key driver for elective neck treatment. If the DOI is 5 millimeters or greater, you must treat the elective neck, even if it's clinically N0, because of that high occult nodal risk.
Anchor 3. The board default definitive dose is 70 grays and 35 fractions with IMRT. You have to know your SIB hierarchy. 70 to GTV, 63 to high-risk CTV, and 56 to the elective neck.
Anchor 4. Do not overuse chemotherapy. T1 to T2N0 is often treated with radiation alone. If you need concurrent therapy for advanced disease, cisplatin is the standard radiosensitizer.
Anchor 5. Brachytherapy is a specialized definitive option that's reserved for select early T1, T2 oral tongue and floor of mouth lesions. It requires high expertise and very careful assessment of the implant geometry and how close it is to the mandible.
And Anchor 6. Avoid brachytherapy near bone. Gingiva, hard palate, and the retromolar trigone are absolute contraindications because of the prohibitive osteoradionecrosis risk.
Yeah, mastering those 6 points gives you the confidence to manage these complex scenarios correctly. Let's finish up with some board-style questions to really lock in the decision-making.
Okay, question 1. A 68-year-old man has a T2N0 floor of mouth squamous cell carcinoma. He has severe pulmonary disease, he's on home oxygen, and has decompensated heart failure, making him a prohibitive surgical risk. What is the most appropriate management?
The best answer is definitive radiation to 70 gray with elective nodal coverage. We have to pursue a curative outcome. This is early-stage, potentially curable disease, and the patient is medically inoperable, the M in MRU.
Question 2. A 70-year-old woman, T1N0 lateral oral tongue SCC, with a DOI of 6 millimeters, refuses surgery after thorough counseling. Brachytherapy expertise is available at your center. What's the best approach?
The best answer there is interstitial brachytherapy to a definitive dose, but paired with elective neck management, EBRT to 56 gray. We select brachytherapy because of the patient refusal, the R in MRU for the small lesion, but the elective neck EBRT is mandated by the DOI being greater than 5 millimeters.
Perfect. Question 3. Which tumor location is the poorest candidate for definitive interstitial brachytherapy due to proximity to bone and ORN risk?
The best answer is the lower gingiva adjacent to the mandible. It just fails that avoid bone proximity rule.
That really covers the core curriculum for this. But before we wrap, I think we should dedicate a little time to the larger controversies and, what's evolving here.
Yeah, the main clinical tension really lies in the boundaries of those MRU rules. The enduring controversy is that temptation, which is often driven by patient desire, to offer definitive chemo-RT for patients who are
Yeah.
technically operable.
It's that constant pull toward organ preservation.
Exactly. We know we can preserve the tongue with radiation, but we have to constantly weigh the local control rate and the functional outcome against primary surgery. And the evidence base right now maintains that the higher local control, the lower ORN risk, and often the better long-term functional status you get from surgery for operable T2 and larger tumors. It just outweighs the temptation to irradiate.
So, what about emerging controversies that are maybe moving the needle, potentially even shrinking that MRU niche?
I think the most significant change is the advancement in surgical techniques, specifically transoral robotic surgery, or TRS. For small, very selected T1 and early T2 lesions, TORS offers a much less invasive approach with faster recovery and potentially lower functional morbidity compared to the traditional open surgery.
So, a patient who was previously inoperable might now be a candidate.
Exactly. If a frail patient who previously would have gotten definitive radiation can now safely undergo TORS under a brief anesthesia, the whole necessity for radiation just disappears. The evolution of minimally invasive surgery is constantly moving cases out of our definitive radiation domain.
That's a critical point. The definition of medically inoperable is fluid. It's based on what anesthesia and surgery can do. What about systemic agents? Anything challenging the cisplatin standard?
While cisplatin is still the undisputed champion, the exploration of immunotherapy, IO, in combination with radiation is advancing really rapidly. Although the trials specific to definitive OCC are still maturing, the role of PD-1 inhibitors as radiosensitizers or as maintenance therapy is a major area of investigation.
So, it could be an alternative for frail patients one day.
It might eventually provide a better, less toxic alternative to cisplatin for frail patients, but for now, it's strictly investigational outside of a clinical trial.
Okay, let's summarize the major takeaways from this highly technical session.
We established that definitive radiation for OCC is a niche treatment. It's reserved strictly for those three indications: medical inoperability, patient refusal, and unresectable T4B.
The technical standard is 70 gray in 35 fractions with IMRT, and we must always address the elective neck if that depth of invasion is significant, typically 5 millimeters or greater.
We reviewed the high-yield brachytherapy option, emphasizing it's for select, non-bone invasive early tongue or floor-of-mouth lesions, and it must never be used near the gingiva, hard palate, or retromolar trigon.
And most importantly, we learned that proper pretreatment dental clearance and aggressive toxicity mitigation are absolutely essential to manage the substantial acute mucositis and the late ORN risk that are just inherent to these definitive oral cavity doses.
Mastering this definitive niche just ensures that when primary surgery is impossible, you still have a robust curative treatment plan ready, and it's grounded in radiobiological rationale and clinical evidence.
This whole discussion has been centered on treating the known tumor volume and the regional nodes. But in our next session, we're going to tackle a complication that drastically changes your field design and dose painting: extensive perineural invasion, or PNI, and its potential to track toward the skull base.
Oh, that's a huge topic. When pathology reports extensive PNI, or when your imaging shows nerve enlargement tracking towards the skull base, you have to know exactly how to extend your target volumes proximally. This means covering the entire length of that cranial nerve pathway.
So we'll cover the complex anatomy of the V2, the maxillary and V3, the mandibular branches of the trigeminal nerve, the specific imaging triggers on MRI that mandate skull base coverage, and the precise decision framework for how far you extend that CTV coverage up to the foramen ovale and rotundum.
Complete practice oral boards at radonsmartlearn.com and subscribe to Radon Smart Review for our next episode. Thanks for tuning in.